Hello everyone, my name is Tanner Smita, and I am affiliated with the University of Pittsburgh Department of Emergency Medicine. Today, I'll be presenting an evidence-based cardiac arrest resuscitation protocol for volunteer fire department-based first responders aimed at improving survival rates from this deadly medical emergency, specifically in communities where EMS response times frequently exceed 4 minutes. It is my hope that the implementation of the methods employed in this protocol will improve the success of early resuscitation efforts and lead to an increased number of neurologically intact cardiac arrest survivors in rural and semi-rural communities across the United States. As part of this presentation, I will introduce the value of first responders in this context, summarize a series of interviews I conducted with 12 firemen from 4 volunteer fire departments about their current management techniques, and walk through the proposed protocol as well as some of the peer-reviewed medical literature that supports each step. But before jumping in, I would like to take a few moments to outline cardiac arrest as an entity for those who may not be familiar with some of the details surrounding this medical emergency. So, cardiac arrest is defined as the sudden inability of the heart to generate blood flow, caused by dysfunction in the electrical pathways of the heart. When this occurs, perfusion to the brain and other organs drops to zero, which causes an immediate loss of consciousness and rapidly progressing hypoxia-mediated tissue damage. If the heart's ability to pump blood is not restored, irreversible damage happens within minutes. And every year across the United States, EMS providers and first responders encounter and attempt to resuscitate over 80,000 sudden cardiac arrest victims. And now, just in terms of sheer numbers alone, it is clear that this is a significant public health problem. But there are other unique qualities of cardiac arrest that make it an interesting medical condition. One example of this is the high and enduring mortality rate. Adult patients that suffer sudden cardiac arrest have only a 10.4% chance of surviving to hospital discharge in the United States, according to the American Heart Association's Heart Disease and Stroke Statistics Update published in early 2020. This mortality rate has stayed relatively similar on average over the past decade, despite intensive research and innovations in the standard of care for these patients, both in terms of pre-hospital management and post-arrest care in the ICU setting. And the cause of these sobering statistics, aside from difficulties with resuscitation research, stem from the fact that the management of cardiac arrest is an entirely different animal than the management of the majority of medical conditions. For more familiar disease processes, such as diabetes, kidney failure, or even more acute conditions such as ischemic stroke, the battle to treat these patients and lift the burden of disease plays out over hours, months, weeks, or even decades. But once an individual suffers a sudden cardiac arrest, the war to save them is lost if purposeful, invasive intervention is not performed within minutes of pulselessness. To address this critically different management technique, systems of care that stretch from first responders all the way past ICU discharge must be present in every community in order to save cardiac arrest victims. The first point of contact with these systems of care is the set of interventions performed by pre-hospital providers when they arrive on scene of a cardiac arrest after a 911 call is placed for an unresponsive individual. In the literature, it has been firmly established that the success of these interventions is dependent on how quickly they are initiated. One often cited statistic is the estimate that a sudden cardiac arrest patient's chances of survival decrease by 10% for every minute the performance of chest compressions is delayed. Defibrillation during the first 5 minutes of an arrest, when the patient is still in the electrical phase, has fantastic success, but these cases are few and far between, and much of the evidence of this comes from casinos and airports where people are under constant surveillance and public access defibrillation programs have been well established. And because of this, much emphasis has been placed on improving early response, but the rapid initiation of care is next to impossible to obtain in many areas. Specifically, this is a big problem in rural and semi-rural communities that are served by underfunded EMS agencies with a massive service area, a situation encountered by thousands of providers and patients every year. In the area where I work, on top of the issues I just mentioned, bystander CPR rates are extremely low. Public access defibrillation is virtually non-existent. The population skews elderly, carries a high burden of chronic respiratory and cardiovascular disease, and is disproportionately of a low socioeconomic status. This is a perfect storm for poor cardiac arrest outcomes. And from what I can tell, things are not going to be getting better anytime soon. The number of agencies and EMS providers is steadily declining, and response times are at risk of increasing even more in some areas. But it is my belief that volunteer fire department members distributed throughout these communities hold one solution to the low survival rates that are experienced, in part due to these extended response times. There are several reasons why volunteer first responders are valuable in this context. And so first, fire departments, at least in the area where I work, serve about 1/3 the area of one EMS agency. At a basic level, this obviously allows faster delivery of an AED to the scene of a cardiac arrest when it is dispatched to both fire and EMS than if EMS responds alone. In addition, the members of volunteer fire departments are distributed throughout their community as they go about their daily lives and are alerted to priority dispatches through the use of pagers or smartphone applications. And so this means that there's a chance a fire department member is closer to the cardiac arrest than the department's AED-equipped squad vehicle and EMS. And so whenever they get this priority dispatch on their phone or they get paged, this individual or individuals can respond on foot or in their personal vehicle to begin providing continuous chest compression CPR if bystanders are not already doing so. And again, this is a big problem in a lot of communities, low bystander CPR rates. So this is incredibly valuable. It allows them to begin acting as a surrogate pump for the heart early, and it slows tissue damage until the AED from their station arrives on scene. And so on a purely logistical level, the dispatch of volunteer fire department members to cardiac arrest in the community they serve will improve the time that elapses between the arrest and the subsequent provision of chest compressions and defibrillation. This alone would likely improve outcomes, but there is undoubtedly more that can be done in terms of the clinical management of this medical emergency. On this front, the peer-reviewed medical literature that has examined pre-hospital resuscitation paints a reasonably clear picture. At this time, the data suggests that survival is maximized by early utilization of cardiocerebral resuscitation, which emphasizes 200 continuous pre-shock chest compressions, passive ventilation, and immediate post-shock compressions in the early phase of cardiac arrest resuscitation. As part of this presentation, we're going to discuss each step that applies to first responders and outline the supporting evidence. But before beginning, I would like to outline the series of informal interviews I conducted with fire department members before beginning this training initiative in our community. Luckily, we have a number of fire departments in our area that are dispatched to priority medical calls such as cardiac arrest, so I was able to connect with a lot of people who had experience in this arena as volunteer first responders. I spoke to 12 firefighters from a total of 4 volunteer fire departments about current management techniques. Each department's members reported defibrillation immediately following AED pad placement, utilizing early bag valve mask ventilation, and the performance of pulse checks following each defibrillation attempt. The evidence suggests that each of these practices are detrimental to patient outcomes, and over the next few slides we will discuss why and what we can be doing better. Now, I would like to say that we are very fortunate to have these individuals in our service area, and their actions in terms of early chest compressions and defibrillation is undoubtedly saving lives. I have nothing but the utmost respect for the dedication of these first responders. But it is also undeniable, based on the details I just mentioned, that more rigorous, protocol-based training in the precepts of cardiocerebral resuscitation will make the early, life-saving care they provide even more effective. And I think this will become very clear as we walk through the steps of CCR as performed by first responders. This slide depicts the quick reference protocol sheet that I have given to fire departments in my service area. Feel free, as we proceed through each step in a more granular fashion, to jump back to this screen and see everything in context. And so I think that the most illustrious way to introduce this is to walk sequentially through a cardiac arrest resuscitation in the order that interventions would actually be performed by a first responder. So imagine you're hanging out at the station with a few of your friends on a Saturday morning, washing your engine, when an arrest is dispatched in your community. You jump in the AED-equipped squad and tear out of the parking bay, lights and sirens all the way to the scene. And when you get there, you jump out of the truck and run into the victim's house, where a man in his 60s is lying on the floor of his kitchen. His wife is standing there, terrified at the turn of events and not performing bystander CPR. So you verify that the man is unresponsive, pulseless, and begin chest compressions. A few quick questions determine that the arrest occurred about 5 minutes before you arrived on scene. It took 1 minute for the wife to attempt to wake her husband, 1 minute for the 911 call to be made and a priority dispatch to be sent out, 3 minutes, that's your response time to the scene, and then the seconds it took to reach the patient, verify arrest, and begin compressions. And so as you compress, your friend rips open the victim's shirt, applies the AED pads, and prepares to shock. But at this point, only 35 compressions have been performed. Cardiocerebral resuscitation emphasizes the performance of 200 pre-shock compressions immediately before the delivery of the first shock. If fewer compressions or no compressions are delivered before the defibrillator is used, the effectiveness of these early shocks may be decreased. What I recommend is starting compressions, following your AED's prompts, pausing for rhythm analysis if needed, and then, if a shock is recommended, perform 200 more compressions before delivering the shock with the shortest possible time between compression pause and the actual delivery of the defibrillation. And so I'm going to give you what we think the physiological reason for this is, and then I'm going to outline the data that suggests this is a possible life-saving adjustment. First, the physiology. In the initial minutes following a cardiac arrest, blood shifts from the high-pressure arterial side of the circulation to the low-pressure venous side. This causes the right side of the heart to increase dramatically in size, and this size increase, the volume increase inside the pericardial membrane, leads to pericardial restraint, which is thought to prevent efficient perfusion of the heart via the coronary arteries. And therefore, if this blood is not redistributed by a full cycle of chest compressions, even successful defibrillation will not be able to restore a sustained perfusing rhythm. Several studies, both in the laboratory setting using animal models and studies conducted in the clinical setting, have shown benefit to pre-shock compressions. One randomized trial, Forstadter Wick, showed that for response times greater than 5 minutes, survival to hospital discharge was 22% for those treated with one cycle of pre-shock compressions, in comparison to 4% in those whose rhythm was analyzed and a shock was delivered prior to the performance of CPR. Another observational study by Valenzuela et al. Demonstrated a 0 out of 21 first shock success rate in a service area with a mean response time of 6 minutes and 21 seconds. This benefit is backed by work done in porcine or pig models of cardiac arrest. All the evidence I was able to find points to pre-shock compressions being a good idea, and none of the studies suggested any harm whatsoever. So CPR stands for cardiopulmonary resuscitation. Chest compressions take care of the C portion of the paradigm, the cardiac portion, but what are first responders supposed to be doing to address the pulmonary system and maintaining adequate oxygenation in these patients? In the interviews I conducted, the firefighters cited the use of BVM ventilation. However, the early use of BVM in resuscitation may have negative effects for these patients. Just like all forms of positive pressure ventilation, BVM usage increases intrathoracic pressure, the amount of pressure that is contained within the chest. And just like all fluids, blood flows from areas of high pressure to areas of low pressure. And therefore, high intrathoracic pressure impedes blood return to the heart, which decreases preload, a measure of the amount of blood in the ventricles, which diminishes the efficiency of compressions. In addition, observational studies have shown that during stressful situations such as cardiac arrest resuscitation, pre-hospital providers ventilate at approximately 3 times the guideline recommended rate on average. This not only increases intrathoracic pressure, but also increases the amount of air that is delivered to the stomach. This gastric inflation, or insufflation as it is sometimes referred to, often leads to vomiting. Aspiration of gastric contents or contamination of the airway with vomit can lead to the development of respiratory infections. And this is a frequent comorbidity and cause of death in the ICU setting due to the immunosuppressed state that these patients find themselves in. In order to address this problem, Cardiocerebral Resuscitation Guidelines recommends the use of passive ventilation to maintain adequate oxygenation. This method entails the placement of a non-rebreather mask over the arrest victim's mouth and nose, delivering 15 liters per minute of 100% oxygen. This should occur immediately following the placement of AED pads during the 200 pre-shock compressions we discussed. As pressure changes within the patient's chest during each compression, an increase with each downstroke and a decrease when you allow the chest wall to recoil, this cyclical variation draws air in and forces air out of the patient's airways. With a non-rebreather mask in place, this exchange can keep arterial oxygenation high enough to prevent permanent damage for as long as 16 minutes after the initial arrest. And by this time, EMS will be on scene performing advanced airway management, maintain oxygenation in this fashion, or ideally, the patient will have a pulse and can be ventilated safely if they are not spontaneously breathing. After performing 200 continuous pre-shock compressions, during which AED pads are attached and passive ventilation is initiated, a shock should be delivered with the shortest possible pause after compression stop. After this first shock, the firefighters I interviewed reported pausing to perform a pulse check. However, the peer-reviewed medical literature shows that this may be a waste of time and could possibly even be detrimental to patient outcomes. Cardiocerebral resuscitation recommends the immediate performance of 200 post-shock compressions following each defibrillation attempt with minimal pause, ensuring that the shock interrupts forward blood flow for the smallest amount of time possible. Studies have shown that for the majority of patients, defibrillation will lead to a non-perfusing rhythm. The mean interval for asystole following a shock for patients who eventually achieve ROSC, or return of spontaneous circulation, is 77 seconds. During this period of time, it is essential that first responders continue compressions in order to maintain perfusion to the brain and heart. Checking for a pulse immediately following a shock is unnecessary and sabotages the favorable hemodynamics, the high coronary perfusion pressure, that improves the patient's chances of achieving ROSC. And that concludes the discussion of direct interventions that volunteer fire-based first responders can employ to improve survival rates from sudden cardiac arrest in their community. However, there is one more thing that can be done to ensure high-quality continuity of care for these patients. For us, in the pre-hospital environment, we go home as heroes if we get pulses back in the field. We take the patient, drive them at exorbitant speeds to the nearest ER, eat an ice cream sandwich from the EMS room, and then head back to our station to tell a dramatized, self-flattering version of the resuscitation to our dispatcher. But for the patient, their fight for survival and a return to normalcy has just begun. It is very important for these patients that they are transported to a facility that is a designated receiving center for victims of cardiac arrest. In-hospital interventions such as emergent percutaneous coronary intervention, therapeutic hypothermia, and high-level ICU care by experienced physicians have an impact on the survival of these patients as well. In the rural and semi-rural communities that this protocol is meant to benefit, a facility that offers these therapies may not be close enough to allow transport of these often unstable patients by ground. If air medical transport is available, I recommend the use of this incredibly valuable resource to get these patients to the highest standard of care possible. The recommendation I made to the fire departments in my service area is to put a helicopter on standby if the patient is less than 80 years of age, suffered a witnessed arrest, and bystander CPR is in progress when first responders arrive on scene. Now finally, before we conclude this video, I would also like to say that quality assurance is very important for any fire department that would like to begin responding to cardiac arrest in this manner, or for EMS agencies that want to ensure that the fire departments they are training according to these methods are performing the protocol correctly. For the departments I have presented to, I have given them sheets of paper that have the protocol that you've seen before printed on one side, and a QA document with these questions printed on the other side. And so these documents, they not only reduce the cognitive load of providers on scene, but they also provide a way for first responders to review their own performance after the resuscitation concludes. That is all I have for you today. The citations of scientific literature used to inform this presentation are included in the description, in addition to my contact information. Please feel free to send me an email if you have any questions or have an issue with how any of this information was presented. If you would like to implement the cardiocerebral resuscitation protocol in your service area, I would be happy to get in contact with you and send copies of the materials being used to present this to fire departments, in addition to the QA documents that help to ensure continued adherence to the listed methods. Thank you very much for listening.